Welcome to Progenesis webinar session number 19. Today's topic is endometriosis and PCOS. We're going to be talking about symptoms, diagnosis, and treatments. And we are very pleased to have a wonderful panel of experts, fertility specialists. We have with us Dr. Hutchison. He's trying to get his connection adjusted. So Dr. Hutchison is Associate Professor of OBGYN and Division Director at Reproductive Endocrinology and Infertility at the University of Arizona. He's also owner and physician at Reproductive Health Center, IVF Tucson. We have with us Dr. Awonuga. He is professor at the Department of Obstetrics and Gynecology, Wayne State University, School of Medicine. And we have Dr. Brown. He is the medical director at Brown Fertility. Thank you so much for accepting to join this panel. Thank you for joining. We're gonna start the conversation about endometriosis and PCOS. And we'll start with you, Dr. Brown. If you can give us some basic information for patients that are trying to understand what endometriosis is and what's the impacts on fertility.
Sure. So in describing endometriosis to our patients, especially after surgery where it was surgically proven, we're very careful to describe if it's stage 1, 2, 3, or 4 from surgical grading, and describing it to the patient and its effect with cytokine, prostaglandin formation, how it appears to block fertilization in the tube. That appears to be one of the mechanisms for infertility in regard to endometriosis. Patients with milder stages of endometriosis, we will normally recommend simpler treatment options such as inseminations, and patients with more severe endometriosis, it may be going straight to IVF or a trial of inseminations leading to IVF. But we do a full description of endometriosis and how it may or may not cause pain, but it can cause infertility, and how in patients with unexplained infertility, that 65% of patients with unexplained may have been shown to have endometriosis. So we see quite a bit of it. I think in our practice, it's probably upwards of 30–35% of patients will have endometriosis related to their infertility, or it's a concomitant issue with other reasons for their infertility, such as male factor or ovulation dysfunction. So it's something we see on a day-to-day basis, and we can usually work around it or with it.
That's great to hear. Dr. Awonuga, let's talk about PCOS. Can you tell the patients what PCOS is, what are the syndromes, and how does it impact fertility?
So polycystic ovary syndrome is a conglomeration of three things. There's been controversies initially as to what actually constitutes polycystic ovary syndrome. But I think that in 2013, I believe, at Rotherham, the experts came together in a consensus conference to actually put everything together. And now we believe that patients must have two of three features that I'm going to talk about now. They must have either chronic anovulation, meaning that patients do not ovulate, and that presents most often with irregular menstrual period. So if somebody has irregular menstrual period, that woman is unlikely to be ovulating. So lack of ovulation is one. The second criterion is hyperandrogenemia, and that can be either clinical or biochemical. And what I mean by clinical is, characterized by either hirsutism, also excessive hair growth, or acne. And sometimes in some people, it can actually be associated with hair loss also. and most of it is male type baldness. But that is, is not very common. And the third factor is polycystic ovaries on ultrasound, and that has a typical appearance when you do ultrasound. And the best way to do the ultrasound is transvaginal. There was an issue as to how many of those tiny follicles that you see on the ovaries called antral follicles that will constitute, apart from the appearance, that a woman has a polycystic ovary, polycystic ovaries. Initially, it was thought that you needed only 12 follicles, but you can get 12 follicles even in young women, especially in adolescents. So the number of follicles that constitute polycystic ovary syndrome has been moved to over 20. So you should have 2 out of all those 3. So once you have those 2 out of those 3, there was 2 out of chronic anovulation, excessive hair growth or hyperandrogenesis, and polycystic ovary syndrome. So any 2 of those 3 constitute PCOS. And that actually means that there are 4 phenotypes of this condition. Okay, and we can discuss the phenotypes as we move along.
Thank you so much. Dr. Hutchison, while talking to Dr. Brown, he mentioned that he sees about 30 to 35% of unexplained infertility that are endometriosis based. Tell us about your experience with your patients and what do you normally see and how do you treat it? What options do you have for patients?
So yeah, so I would concur. It's a huge percentage of that unexplained population, because I think there's those studies that go back years ago where they would do random biopsies on patients, random peritoneal biopsies, and you could find plenty of, I think it was 15% of the random biopsies showed endometriosis, and pretty strict criteria, right? Like they had to see gland stroma and hemosiderin-laden macrophages. So I typically tell people, that I feel like most of our patients who are unexplained have some degree of endometriosis as part of the picture. But I'd be interested to know what you two feel about this. But I think going back to it was like 1996 with that Sophie Marcoux study that showed that, doing, resection of endometriosis was, really resulted in a very modest improvement in pregnancy rate. So I'm not a real big fan of surgery unless people are having a lot of pain or pain with intercourse or whatever, or if they've got like painful endometriomas or whatever. But even with the larger endometriomas, I'm reluctant to do surgery on them just because you're going to wind up with less eggs, on the flip side of it as you go to IVF. But what was your other question?
And in terms of treatment, I mean, you're already talking about the treatment options for patients that are, exhibiting endometriosis.
So, yeah, if they want to get pregnant, this is for the fertility patients you're talking about, yeah. So you don't really have a whole lot of good medical options if people are trying to get pregnant. As far as, but you do have some like the temporizing measures, and certainly things like Lupron, and continuous oral contraceptive pills, and then even adding Lupron or adding letrozole to the oral contraceptive pills continuously, I found was really good for pelvic pain. But boy, if they're trying to get pregnant, you're kind of painted into a corner. I have, at that last IVF meeting to be at Coronado, I thought it was really interesting, all that talk about the endometrial biome, kind of pushing development of endometriosis through perhaps, abnormal peristalsis of the uterus, kind of weird contractions. So I've been really big on telling people to eat their fermented food every single day, trying to do either the kimchi or the cabbage or the active culture pickles. And it's so anecdotal because, when you're in a smaller community like ours and you're only doing, 150 or 200 IVF cycles a year, it's hard to, really keep track of how things are really influencing things, because there's so many variables that make the pregnancy rates get better. But I honestly feel like our pregnancy rates have gone up with the addition of those fermented foods, and then being really firm about telling people to avoid junk food. Because I mean, to me, anecdotally, I think we've had way more endometriosis patients conceive spontaneously. And certainly in the early stages of the quarantine, we had a lot get pregnant. And maybe that's just because they're home and they're having intercourse, where they haven't been before. But yeah, I really feel like that has made a difference. But I'm interested in the other two, how they want to approach that.
Yeah. We have a number of questions from patients that have asked, and we have some patients that wanted to ask live. Maybe Miriam can take some of the questions from patients, and then we'll start with Dr. Brown. Can you take one of the questions on?
Sure.
Sure. I'll read off the first question. It's from, the patient's name is Mallory. She's 35 years old, and she had her embryos PGT tested. She was also diagnosed with severe endometriosis by laparoscopic surgery in May 2018. So since her surgery, she went through 3 retrievals and 1 failed FET. And she also states that her pain has continued to get worse. So Mallory asks if there's any benefit to another laparoscopic surgery before another fresh embryo transfer.
It's a good question. It covers a lot of bases. And I agree with what Dr. Hutchison was saying. But just in general for Mallory, the old dogma was IVF bypasses endometriosis as the problem, but we're not sure if that's 100%. And I agree with Dr. Hutchison that there may be other inflammatory issues or other things that are involved in a percentage of patients. I agree with that. But for this patient, having surgical proven endometriosis and treatment, the great majority of the time it will come back. And what's unique about endometriosis is it usually comes back to the stage it was found surgically, and however it was eradicated, either with excision, ablation, or peritoneal stripping, what have you. It almost always comes back to the stage it was found, stage 1, 2, 3, or 4. So normally we wouldn't repeat the surgery on a patient like Mallory unless she was having pain, something symptomatic in regard to her quality of life. We wouldn't do it in regard to fertility treatment per se, and we would pursue her embryos that were cryopreserved. And she had aneuploiding testing of her embryos. That does give you somewhat of a better set of embryos to work with. And I would normally ask her to forge forward with using those embryos in the form of what we call an FET cycle, or frozen embryo thaw cycle. And then we always stretch back in our minds, like, there was a time where we would put patients on Lupron for 3 or 6 months before using their frozen embryos. And the data was conflicting. And maybe, again, in a subset of patients, it is helpful. So in her case, just the way we would probably handle it in this part of the country is to try those embryos. Just put them in, give them a chance. We use Lupron in our standard FET cycles, and there's going to be some advantage from that in decreasing some of the endometriosis inflammation and cytokine production. But that's how we would handle somebody like Mallory, and she's not a lost cause, depending on her age, and her age is a very powerful part of this, and sounds like she's headed in the right direction.
Very good. Any suggestion on nutrition?
I agree with Dr. Hutchison. I think, any type of food intake that might decrease inflammation or possibly could be helpful. I don't have a standard diet I would put patients on, but I'm very interested in hearing, about the data in regard to what Dr. Hutchison's speaking to.
Very good. Dr. Hutchison, you want to make a comments before we go into the next question?
Well, I'd like to know from the other two, have you had much experience with the endometrial receptivity testing, the EV deal that for endometriosis patients?
I have had some experience with ERA testing, and not so much specifically the endometriosis patients, but kind of we have it as an elective for our patients. It's not mandatory. And it does seem, we actually have run the data internally in our office. We're a pretty high volume center, and it does seem to be somewhat helpful. I was surprised. I didn't think it would be. I was kind of a naysayer in regard to ERA testing, but my partner, Dr. Bruce Rose, he's really showing us that, objectively from our patients, these patients are randomly acquired. It's not an objective study, but it looks promising in that group of patients. Pregnancy rates have been really good, statistically higher than those that aren't using it. So we're looking at that pretty intensely. And I got to admit, I was a naysayer initially, and I'm starting to see the light, at least from what Dr. Rose is showing us from internally in our center.
Yeah.
I come in here. I'm a little bit, I'm a skeptic when it comes to AR testing, and the reason why I'm a skeptic is that most of the studies that I've seen, they have not been in patients in whom their embryos have been tested. So if the embryos have not been tested, you don't actually know where you are.
I agree.
So it's only when we have studies in which embryos have been tested and are then randomized to look at this subject. I think it's difficult to say at this stage whether in fact it has any significant impact on pregnancy rate. The other thing that I would say is that people should not forget that even with embryo testing, the pregnancy rate is never 100%. And if you look at the way the embryos the samples are from the blastocysts are biopsied and subjected to testing, it depends on where. If you're lucky, for example, and you take the biopsy in an area where the cells are aneuploid or even euploid, you can get a normal result, whereas the embryo itself in the inner cell mass is actually abnormal. And that's the reason why the pregnancy rate is never 70%. For this patient, I would just say, go ahead and just try again, and hopefully she gets pregnant. And most people will, especially if she has many euploid embryos frozen. And that's.
If I can make a comment, I agree. We're now in the realm where a lot of us are doing single embryo transfers, and I think you're right. And with even though PGTA testing isn't the most sensitive or specific test yet, because of mosaicism and what have you, I think we're close. I mean, maybe even donor egg recipients that have endometriosis might be a great model for this. But you're right. It'd be nice to know with 100% sensitivity and specificity if that were euploid embryos going, especially from a young egg, a donor egg. Studies using those would be very meaningful. I agree. But we don't have the answer currently. I agree with you.
Yeah. Miriam, can you take the next question?
Yes, so our next question will be from Cara, and she will be asking it live.
Hi, my name's Kara. I'm 32 and I have lean PCOS. And my question is, what are the different treatment options for lean PCOS versus, people that are bigger with PCOS? And what are your thoughts on the use of metformin if you are not diabetic, coupled with letrozole?
Let's start with Dr. Awonuga, and then we go through the panel.
So question is whether in fact Kara wants to get pregnant or not.
Yes.
You want to get pregnant. So for me, I actually do not use metformin unless I have it's proven that the patient is either insulin resistant or pre-diabetic. I don't use metformin. And I do a 2-hour test with insulin levels on all my patients. So I do what's called World Health Organization 2-hour glucose tolerance test using 75-gram glucose. And I measure the glucose and insulin in the fasting state, and I do it again in 2 hours after that. It's only when there are criteria for determining whether a patient is insulin resistant or pre-diabetic. So if a patient is not insulin resistant, I do not use metformin. I do accept that some people might not agree with that, but that's what I do. I believe that I have a reason to give metformin before I give it. So If you are insulin resistant, yeah, metformin will help. But if you're not, then from my own point of view, I don't use it. And not all patients with polycystic ovary syndrome are insulin resistant or pre-diabetic. So in terms of treatment, it depends on how far you want to go. And you're young. How old did you say you are again?
32.
32, you're young. So it depends on, one, how desperate are you to get pregnant? Two, how much what kind of pregnancy rate are you happy with? And three, what's the success rate that you like to see? And using those three criteria, I'll then give you an option as to which way you need to go. And the question is, what kind of PCOS do you have? You know, I did mention earlier on there are 4 phenotypes. So are you an ovulatory type PCOS, or are you not an ovulatory type PCOS? And again, that will guide my advice to you as to what kind of treatment you do.
I do not ovulate if I'm not on letrozole.
Okay, good. So letrozole, timed intercourse, all right? That, as long as you ovulate, that might actually bring you to the normal pregnancy rate at your age per cycle, which we call the fecundability rate. So and that would be about around 15 to 20% per cycle. And you have to understand that if you go for timed intercourse, all right? So it depends on what you want. And IUI, intrauterine insemination, may actually increase that a little bit more, you know, but for your age, it might actually increase it a little bit more, you know, and you may want to do that. So it depends on, like I said, those 3 factors. How desperate are you to get pregnant? How much money you want to commit to it? And what kind of success rate are you happy with? And IVF is always there, and that will give you the best pregnancy rate.
Thank you.
Thank you so much. Dr. Hutchison, what's your comments on this?
Yeah, I think that the lean PCOS patients are particularly difficult to manage most of the time. I tend to tell patients with regard to metformin, I agree with Dr. Awonuga about, you know, if they're really not insulin resistant, it's not going to help a lot. But even the thin ones can be fairly insulin resistant.
Sure.
And I'll tell you, I think I tell them that the metformin, and I like to use a gram in the morning and a gram at night of the extended release, is just to punish them for eating carbs. Okay, that's it, you know, because we really have a very disordered eating in our society, and you know, pretty much, you know, our daughter was home, you know, for a vacation a while ago from where she lives in DC, and so we were sitting watching TV, which we normally don't do, and she turned to me and said, you know, you shouldn't eat anything that they advertise on television, you know. And we have become normalized to large amounts of refined carbohydrate, which just makes the problem of managing these patients so much worse. Have you two used inositol much in the last couple of years?
I have. I was involved in those original studies where they almost got it approved by the FDA in Richmond.
Oh, really? That was Virginia, right?
That was back in like 2000, 2001 in Richmond, Virginia. They almost got it approved by the FDA, and you know, it does have a positive effect. I can't remember all the details, but I'm definitely seeing a resurgence in it. More and more patients are using it as a supplement, and there is a positive effect in there. You can feel it, and the only problem is I'll have patients coming in with PCOS that ultimately might be going to IVF, and I have to get them to discontinue the medication. I'm afraid it may interfere with what we're doing, but you can sense there's a positive effect in there. I can't put a finger on it, but I don't know if you feel that as well.
Definitely. Yeah, I think it's made a big difference. And you know, the literature is so sketchy, and part of it is there's no money in it. And I think wasn't that part of why they kind of stopped the whole approval process, because they're like, we're never going to make our money on this thing. But yeah, I think at 2 grams twice a day that I see them, it's easier to get them to ovulate with that on board.
Very good. Thank you so much. Miriam, can we take the next question?
Yes, our next patient, Jenna, is 34 years old who was diagnosed with PCOS, and she also has a difficulty increasing her endometrial lining. So she says it can go past 6 to 7 millimeters. Her current protocol is Lupron, estrogen patches, estrace, Viagra, progesterone and oil, as well as an antihistamine protocol, and she also takes vitamins. Patients had 2 previous miscarriages when trying to conceive naturally, and she also had 1 unsuccessful fertility cycle. She is 5'2", 165 pounds, and is very active. So she was wondering if any of you can give her recommendations for preparing for an FET when you have PCOS.
Dr. Brown?
So, yeah, sure. Now, the patient is preparing for an IVF FET cycle with PCOS, and she has a thin endometrial stripe. You know, typically the way we use a kind of an old-fashioned protocol where we use birth control pills, and then we overlap with Lupron to shut down the hormones, and then we bring the estradiol back up, either dermal or oral, and we follow that lining, you know, early, right after menses, before we do the program cycle with estradiol and progesterone. And most patients, you know, just with at least the estrogen regimen we're using, 99% of our patients, the endometrial stripe is greater than 4 to 6 millimeters, and I'm a happy doctor. You know, there's an argument on how thick does the endometrium need to be, and I remember the early days where anything above 4 millimeters was fine, and it's debatable. I know a lot of doctors have a different number in their mind. But we've enjoyed wonderful success with endometrial stripes just before starting progesterone at 6 millimeters, 8 millimeters. Everyone's got a little different line in the sand. So if she's having an endometrial lining of 8 millimeters, I'm a pretty happy doctor. I don't know if I'd blame that as her cause of not getting pregnant.
I think she said she cannot pass 6 or 7.
Okay, she can't get, so in patients where you do need to increase the endometrium, vaginal Viagra, vaginal estradiol, we've had some success with that just anecdotally.
We've done really well with natural cycle on these patients if they keep failing over and over again, a managed cycle. We'll put them on a natural cycle, and we'll go along with their ovulation. As you two are aware, it's a pain in the neck because you got to have everybody around, you know, and and your transfer may be on a Sunday and all that stuff. But I really do believe that, you know, the patient's own pulsatile release of hormone is probably way better than, for some people, than all the estrogen that we can pump them full of. Yeah, the other is sleep. You know, I think there's, you know, we've wrestled with some of these thin endometrium patients for a couple of decades, and you know, there's some literature out there that's saying that growth hormone is really important with endometrial development. And if you're not getting your sleep, then you really may be shorting yourself on that end of it. We've added growth hormone into some of those protocols with some good success, but you know, it's expensive. It's another, you know, it adds another $1,500 or whatever to the program. Yeah.
Very good. Dr. Awonuga?
Yeah, I agree with all that has been said. This kind of situation is always very difficult to deal with. And I mean, what we do, you know, we just vary and do something else next time, not because we know that it will work or is an easy answer, but just to, you know, try something else. And I do accept that natural cycle is an option. As a matter of fact, it has never been shown that the pregnancy rate is better when you use hormones than when you do it in a natural cycle. The only problem with natural cycle, like Dr. Hutchison said, is timing. You know, everybody needs to be around. You know, by the time she's ready for you to put the embryo in, it may be on a weekend, and therefore it's difficult to arrange. The other thing that I've done is to use hormone replacement therapy, using OCP first and Lupron, but rather than escalating the estradiol dose I start them from the beginning on 4 tablets a day, and they can actually put in the vagina, and I just stay the same. So there are 2 regimens. You can go in an escalating fashion, use 2 milligrams twice a day, increase it to 3 times twice a day, and maybe to 4 if the endometrium is still okay, is not okay. But you can start them from 4 right from the beginning. The issue of growth hormone is just expensive. It's extremely expensive. And the other thing is, who knows what kind of, I always keep coming back to this. Who knows what kind of embryo you're putting in? Even in a young girl, if I look at the data from the next gen that does embryo analysis for us, 50% of women that are less than 34, 50% of the embryos they produce are abnormal, even in a young lady. So without testing the embryo, you don't know what embryo you're putting back. There's something that's also that I'd like to ask this lady. Is that 2 miscarriages before, were those miscarriages biopsied, or were the product of conception biopsied in those pregnancies to find out the karyotype of the pregnancies that she lost? Were those pregnancy karyotyped? In other words, did they subject it to chromosomal analysis, those pregnancies that she lost?
Yeah, we don't have data. We didn't have information about the genetic makeup or the karyotype of the pregnancies. And like you said, it's possible that it could be chromosomal as well.
The reason why I say that is that I actually subject all patients who get pregnant from treatment and miscarried. I subject them, all of them, except they refused, to chromosomal analysis. And this is an anecdotal report here now. Nearly more than 90% of them are abnormal. In any case, we've always known that the commonest cause of miscarriage is chromosomal anomaly. But for somebody who's infertile, it's good to close the picture for her. Why did she miscarry? You miscarry because this pregnancy was chromosomally abnormal. And most chromosomally abnormal babies a pregnancy will miscarry anyway. So for her, and even if you look at the literature in patients who have had two losses before, there's a very good chance that their next pregnancy will be okay and be carried to term.
Very good. We may have a live question. Riley, can you look into a live question? Otherwise, we can take a question from Miriam.
Hey, Kristen, are you there?
Yeah, I'm here. Can you hear me?
Yes,
we can hear you.
Hello.
Hi. So I am 37, have been trying to get pregnant since I was 36. I found out during my first ultrasound that I was told I have stage 4 endometriosis, but I haven't actually had surgery to confirm that. And I had multiple consults with different REs who have 80% have told me to proceed with IVF without surgery. About 20% have said to have the surgery first. So we made the decision to move forward with IVF, and I've actually gone through 4 different retrievals, and I have never had genetically normal embryos. So my baseline is usually around anywhere from 6 to 9 follicles. I've made the decision now to have the surgery because the only other recommendation from my doctor was to just go to donor eggs. So without going down that path, I feel like I want to explore having surgery, but I'm just curious. Seems like most of you have said that you don't recommend surgery, but when IVF is clearly not producing normal embryos, I felt like this was just the next best path to, fully try and have my own genetically normal trial. And just curious if you have any additional thoughts on that. And then also about how to proceed after the surgery's done, because I'm scheduled for August 14th.
Very good. Thank you so much. Dr. Hutchison?
Yeah, Kristen, are you having a lot of pain?
Yes. I mean, it's not unbearable, but when I had the surgery consult, the surgeon also said that it looks like, because I have multiple endometriomas and one of them is growing towards my abdominal wall, which I guess could cause some potential health implications down the line. So she said, outside of just trying to get pregnant, which is my primary goal, that she would recommend this surgery as well.
Oh man, I think you're damned if you do, damned if you don't in cases like this, because the endometrium is certainly, if they're getting bigger and they're painful, then it's worth removing them. But you know, the standard procedure to remove an endometrioma really involves peeling them out of the ovary, and a lot of the time they're very dense, deeply applied to the ovarian tissue. And it anecdotally to me, it seems like a lot of patients will develop these endometriomas in the ovary that's actually doing most of the work. And I don't know really how endometriomas are generated, but my suspicion is you get some surface endometriosis and then you get ovulation. And then now as the follicle collapses in, it gets buried, and now you've internalized some endometrial tissue. But you know, trying to wrench that stuff out of there, you're already a low responder, and you're going to be a lower responder on the other end of it, almost for sure. Definitely, I mean, the chance of pregnancy is modest. I mean, you're going to get maybe a 0.5% per month improvement in it. I don't know that it would do, and certainly Dr. Awonuga can address this probably better than I can, but I don't think it would improve your chances of having a genetically normal embryo.
Absolutely. Yeah, I agree entirely. And one question I would like to ask you is, how big are these endometriomas anyway? How big are they?
So, yeah, I think when I first started, there was just one, and I think it was like 3 centimeters or 3 millimeters. I mean,
3 centimeters.
yeah. And then I now have another one, because a lot of the protocol that I've been on is obviously it's estrogen. So there's been another one that's developed on the other ovary as well.
There's none that's up to 5 centimeters or more.
No, I don't think any of them are.
So look, this is my view. Going on to remove a 3 centimeter endometrioma, in my view, I will not advise it. And this is why. Because, like Dr. Hutchison said, you're already a low responder for your age. And when you operate on the ovaries, okay, you remove a lot of oocytes, you remove a lot of eggs, if I put it simply, okay? And therefore, it's going to decrease your ovarian reserve further. Now, and there is no evidence that if you were to operate and treat endometriosis, it will increase your chances of getting a euploid embryo. All right. Now, one of the other things that you have to consider is that at 35, you are 34, yes? One shouldn't be collecting 6 eggs from you, suggesting that you have a reduced ovarian reserve anyway. And for me, if you are adamant on using your own oocyte, I will do as much cycle as possible and bank those embryos so that you have, because sooner or later you're going to need surgery. Okay, so get all your embryos and get them tested. Hopefully you get 1 or 2 as you move along that are euploid. So, but going to do surgery on a 3 centimeter endometrioma when you are a poor responder already, or a low responder, I don't want to use the word poor, or you have a diminished ovarian reserve already, will probably not do you any good. Except, of course, if you have a lot of pain, yes, you can do it for pain, but not for pregnancy, I don't think. Not a 3 centimeter endometrioma, in my view.
Dr. Brown?
Yeah, thanks. One quick question for the patient. Do you have any idea what your AMH level was, and did they use maximum dose protocol on you to get those 8 eggs or so?
So I've done a couple different protocols. My AMH was at 1.1.3, and then it actually increased to 2.4 a couple, like 6 months later. And then I've done your standard like Lupron, and then 350 or 300, 150 Menopur Gonal. And then I also did 1 cycle low stim of Femera and just Menopur. So I've done, like I said, I've done it 4 different medication cycles.
You know, I think all 3 of us, or all the physicians here, I think we all agree. You know, I think taking endometriomas out of your ovaries is just going to hurt your egg supply further. And it kind of feels like you have low egg reserve, just in the sense that if all the embryos were aneuploid, your eggs are kind of acting older.
Oh, yeah.
I'm not sure if it's a medical necessity to have surgery, unless you're having, like the doctors are saying, you know, with a lot of pain. I'm not so much worried about it acting like a malignant cancer and spreading throughout your body. And in rare situations, it'll go to the bowel. But I almost feel like you were alarmed a little more than what we would feel is appropriate. Now, if you're having pain, then that is a reason. I agree with the doctors that, you know, then you have to do something about that. But your egg reserve seems low. And it's one of the things that all of us fertility doctors see, but nobody writes about it. Like patients that have really severe endometriosis. And in lieu of you having endometriomas, we're going to guesstimate that you would probably be stage 4 endometriosis from that ultrasound finding, maybe stage 3, stage 4 endometriosis. So we, in general, call it severe endometriosis just from ultrasound. Normally, it's definitively diagnosed surgically. But in general, we would all agree that you're probably stage 4 or stage 3 severe endometriosis. But what's interesting, and nobody talks about this, is patients with bad endometriosis, even at a younger age, it seems to hurt their egg supply. Somehow is it these cysts, or is it just endometriosis in general that seems to lower the egg reserve? And so you weren't on a maximum dose protocols, and you got a fair number of eggs. And to me, that's a stress test for your ovaries in regard to your egg reserve. And you did okay. To me, the PGS testing or the PGTA testing of your embryos, it's a little unique that they were all abnormal in a 36-year-old woman. So yeah, I don't know. I think all these answers are correct. My take would be you could do up to a maximum of 6 IVF cycles. And then at that point, if you're not pregnant, then we know statistically it's probably not going to work for you. And then going to donor egg at that point would be my choice. But I'm not sure if I'm rushing you to surgery. I mean, but there's these other circumstances that may push you to surgery. I agree.
Thank you so much.
Can I just ask a question? Those embryos that were aneuploid, okay, have you tried, or your doctors tried to rebiopsy them to actually see what the result is? Because why I say that is that 2 reasons why I say that. There's been anecdotal report of mosaic embryos being transferred and a patient ending up with a normal pregnancy. And there was also a report not long ago in which the embryos were rebiopsied and they were actually found to be normal. Because the fetus itself, or the inner cell mass that turns to the baby, normally pushes abnormal cells within it into the placenta, which is where we do the biopsy from, which we call the trophoectoderm. All right, and those abnormal cells in the trophoectoderm are not uniform. So you can take a biopsy in one place of the trophoectoderm and you get an abnormal result, and you move slightly to the left or to the right and take another biopsy and it comes back normal. I don't know. So it may be worthwhile if you have, I don't know, I think that those embryos might have been thrown away now. It may be a good idea to retest them if you still have them to see what you get. Just a thought.
Yeah, and I've got another recommendation is look back on what the abnormalities were, what were the rearrangements, because we found a couple people who had balanced translocations who, you know, they wound up with all of these abnormal embryos, but they were always, you know, like the same you know, abnormality within the within the embryos, or most of them being that abnormality. And then when we carry a type of patient and her husband, we find out that one of the other of them has this balanced translocation. But
yeah, they come back complex abnormal most of the time. So I've only had 4 that have actually been tested, and all 4 were abnormal. So I appreciate the comments.
Yeah, the other quick point, Kristen, is, you know, PGS is not required. You know, doing PGTA is not a necessity. You don't even have, you know, we're worried about the sensitivity and specificity of genetic testing of your embryos, and it's very real that it's not that great. So you don't even really have to do genetic testing of your embryos unless you want family balancing or something. And yeah, I agree. They could be false abnormal embryos, and actually, we would tend to put them in you just to give them a chance, hoping that the good ones take and the bad ones don't. So it's not a requirement to do genetic testing of the embryos.
Yeah, just to add to this, when we look at statistics, looking at more than 37,000 embryos, the euploidy rate at your age should be at least 40%. So you should have 40% euploidy rates. So out of those 4, at least 1 or 2 should be euploid. So rebiopsy and retest is not a bad idea. I would definitely reconsider that.
Okay, thank you.
Thank you. Very good. Miriam, let's get the next question.
Yes, our next question is a question we received on our Instagram from patient Siri. She asks, what is the best form of pain control with those with severe PCOS and endometriosis?
And we're gonna start this time with Dr. Awonuga.
Yes, to be honest with you, I'm not actually sure. If you have a combination of polycystic ovary syndrome and endometriosis, and we're talking about pain only, I probably will go on something to suppress your endometriosis, and I will start with oral contraceptive pills to start with. And if that's not good enough, I'll escalate that, and it may be at the end of the day, I'm going to put you on Lupron. But if I do that, I'm going to put you on Adbac after about, so in other words, I'll put you on OCP plus the Lupron after I've actually given you Lupron for about 3 months just to suppress you. And that's how, and then I can add NSAID to that if you're still not comfortable. And that's the way I would go.
Very good.
If you're not thinking about pregnancy at all.
Thank you. Dr. Brown?
Yeah, in the patient with PCOS and endometriosis pain, is she trying to get pregnant or is she not trying to get pregnant? I guess, in the patient not trying to get pregnant, I'll never forget that Dr. Howard and Georgiana Jones always saying that, Danazol is kind of a lost, wonderful drug. It was really good back in the 1960s and 70s for patients with, and it's kind of a lost art in using Danazol due to its potential risks, but Danazol was great for those not trying to get pregnant. Birth control pills, Lupron. We have all these wonderful tools, Alyssa, GnRH antagonist, surgery for pain. But if she's trying to get pregnant, then we say just get pregnant. We love PCOS patients. They get pregnant. Once you're pregnant, your body makes an ocean of progesterone that'll decidualize all that endometriosis and should help with the pain. So we would say full steam ahead and getting pregnant if you have endometriosis, either with a trial of ovulation induction with letrozole with inseminations, and if you're not pregnant, then consideration of IVF. Yeah, we'd say if you want to get pregnant, full steam ahead, get pregnant. That'll really take care of that endometriosis.
Absolutely. If I can just make a comment that it used to be, I'm Nigerian originally, and back home, people don't have time to have endometriosis. My mother used to say, mother is a qualified nurse. Why? Because you get pregnant, you breastfeed, you get pregnant again. We are all years apart, So you get pregnant for 9 months, you breastfeed for another 9 months, you get pregnant again.
Then have Irish twins.
Yeah.
So when you do that, your endometriosis is suppressed for a long time. And also, pregnancy is also good for PCOS. Because don't forget, one of the issues with PCOS is endometrial cancer. So which a lot of people tend to forget. And that is due to incessant lack of ovulation. So if you get pregnant, you breastfeed, you suppress, not only will you suppress your endometriosis, your lining is protected from the effect of hyperestrogenism from polycystic ovary syndrome. So you're killing 2 birds with 1 stone. And that's what I say, just get pregnant. And your pain will also be controlled for a long time.
Dr. Hutchison, what's your opinion?
Oh, I agree. Yeah, it's, you hear about polycystic ovary syndrome patients tend to complain that their ovaries hurt. And I think part of that may be that, with this not ovulating all the time, that some of those pain fibers kind of regrow back into the ovary, and then they just kind of hurt, and they're big, and they keep recruiting, another cohort or so of follicles, every few weeks or so, and so it's making that ovary stretch. And so I always tell them, like if we can we can move you towards normal ovulation, your ovaries are going to overall, and in terms of volume, they're going to decrease in size, and then once you start ovulating, the pain fibers regress out of the ovary, and that's why most people can have this pretty violent ovulatory event every single month. And like some of them feel it, but most of them don't. Yeah.
Thank you so much. We have one more question live. Miriam, if you can take the question live.
Alia, are you there?
Yeah, it's Alia.
Sorry.
Hello.
Oh, no problem. Hi, my name is Alia. I just turned 38. I've been doing IVF for about 2 years, since June of 2018. And in September of 2018, I had a tubal ligation and a laparoscopic surgery to diagnose and remove my endometriosis. It was moderate endometriosis. So I'm coming up on the 2-year mark, and similar to what we've kind of already discussed, my question was about considering the surgery again. I personally don't believe that it's done me any good. I've had, since the surgery, I've had no success with IVF. I've had 3 transfers at 36 and 37 that were unsuccessful. And also similar to what we were just talking about before, I did notice that my egg quality decreased significantly after the surgery. It didn't necessarily affect my numbers. I've always had polycystic ovaries where I've gotten 18 to 21, 22 follicles, but I had 2 consecutive cycles following my surgery that I rendered no viable PGS tested normal embryos. So since then, my quality has bounced back. I've been able to bank 8 PGS tested genetically normal embryos, and I'm prepping for my 4th FET. So I just turned 38. I'm coming up on the 2-year mark from my surgery. I was interested in, hearing about considering, should I do the surgery again, considering I feel like it didn't do me very much good. That's part of it. And just from the things I've heard so far in terms of not really doing it unless I have a ton of pain, I don't really have a lot of pain. I have, in this last cycle, I got a non-functional cyst that's now on one of my ovaries. I'm guessing attributed to the endometriosis. So I'm kind of worried that as I'm getting older, things are getting worse instead of better. And so I'm just wondering, if it's worth doing the surgery again or other things that I should consider prior to this FET. And I am planning on transferring 2 embryos this next time as well.
Thank you so much. We're going to take all response from all 3 physicians. Whoever wanted to answer first.
I could go first. From what Alia has said, I actually don't see any indication for surgery. There's no evidence that surgery will improve our chances of getting pregnant. Getting pregnant has to do with the embryo and the endometrium. Okay, and surgery for endometriosis is in the pelvis or in the abdomen. And the third thing, the other thing that I would say is that because she already has euploid embryos, putting in 2 embryos instead of 1 would be the way to go, especially if she's had failed cycles before. And I didn't actually get how many FETs he's failed. Okay,
I've had 3 failed. This will be my 4th.
And in all the 3, you had euploid embryos put back in all the 3?
Yes.
Okay. All right. Sometimes this happens and it's very difficult to know exactly why, but the only thing I can say is that I do not believe that going for another surgery will actually increase your chance of getting pregnant. I just can't say it. I don't know what my other colleagues think.
I agree. I think the only reason would be pain. Yeah. I mean, the only potential use for surgery is if you're suspicious of a hydrosalpinx in an IVF patient, then I think that would warrant surgery. But pain's really the only reason, and it really does lower egg reserve by shelling out those ovarian cysts out of the ovary. And yeah, I think pain or a hydro would be the only reason for surgery.
Yeah, I agree that I remember Dr. David Adamson did a pretty big trial on second look laparoscopies in endometriosis patients, and it had no effect as far as improving the chance of pregnancy. You might consider one of those endometrial receptivity arrays or the ERA test, because you have had 3 failed transfers, and you might be, and again, it's like Dr. Brown was saying, it's very controversial, and I know that the Canadian contingent doesn't believe so much in it, and but a lot of the Europeans do, and I think I'm more on board with it than not. But yeah, we found a lot. Actually, the majority of endometriosis patients, I would say, probably 80–90% have. They seem to need more time on progesterone than the 120 hours. And certainly the first one that we had was the first ERA biopsy we did a few years ago was on a woman who'd failed 3 transfers at another place, and then had come over to us and had 2 failed transfers here. And we did the ERA, and she was out at 168 hours. So we transferred at that time. She got pregnant, had a baby. And this couple had been trying for 8 years on their own. And then she called back about a year later and said that she got pregnant on her own. So, the pregnancy probably reset her endometrium as well. So strange stuff, though, endometriosis.
Very good. Thank you so much.
Thank you very much.
Oh, you're welcome.
Very good. We're getting close to the end of the webinar. I am taking a minute to just ask each one of you to introduce your organization and tell us what you do for patients and how different you are in your approach of patient care. And I will start with you, Dr. Hutchison first, and then I'll go with the panel.
I don't know how different we are from anybody else, but no, we're so I have a university appointment, but we have a private practice here in the middle of Tucson, and my sister. So you're seeing my sister's name up on here on the. She is our practice manager, and at least when I see my picture, it's saying Holly Hutchison up there. It's not saying Scott. But yeah, this has been sort of a mission for us, because my spouse and I were fertility patients years ago, and we're lucky enough to have 2 kids. But yeah, it's really kind of it's been a real avocation for us, I guess, to do this practice. But yeah.
Very good. Dr. Awonuga?
Yes, I'm from Wayne State. Ours is an academic program. There are 2 physicians in our program. And we have different special interests. We offer all range of fertility treatment, from egg donation to gestational carrier, IUI, the whole gamut. My special interest happens to actually be polycystic ovary syndrome. I see a lot of PCOS patients in my practice. My partner has special interest in oncofertility. Right? So, but we don't have large number of cycles. The competition here in Michigan is actually quite stiff. So we do less than 100 cycles a year, which is actually very small. So for IVF, I mean. But we treat all manner of patients, and I have a large PCOS patient population.
Thank you so much. Dr. Brown?
Yeah, I'm a Jones Institute graduate from Norfolk, Virginia. I was very fortunate to follow Dr. Howard and Georgiana Jones in their final years of teaching. And so I'm a kind of an East Coast guy. I'm part of a large group here in Jacksonville, Florida, where we also have appointments at the Mayo Clinic and University of Florida, Jacksonville. So we teach residents, and we're a big unit. We cover Central and Northern Florida. We probably do about 600 fresh IVF cycles a year. And we do full spectrum and tubal reversals and gestational carrier treatments as well. Our special interest lately is ovarian tissue cryopreservation. So patients that don't have time to go through an IVF cycle to freeze their eggs with cancer treatments, that we can get their ovaries and actually freeze their cortical tissue for later use, which is kind of an exciting new area for us. We do a lot of egg freezing as well, just in general with IVF. But we're just a big Florida group, and I seem to practice very much like the other physicians in the group here. And yeah, it's kind of a small world we live in. We all kind of do this the same.
Yeah. Very good. Well, thank you so much for the introduction. We are coming to the end of the webinar. Next 2 weeks, August 5th, we will have another webinar with another group of physicians, and we will talk about another topic. So stay tuned and check your email for updates. I would like to thank each one of you for helping us answer the questions from the patients on this very important topic. And I would like to show my appreciation and thank you for your participation. Thank you so much.
Thank you.
Thank you.
Thanks for having us.
Bye-bye.
Take care.